Okay, this recording is for March 2nd, Monday, cardio examination, a Sullivan book, and breathing exercises, Hilligas book. I'm going to start with the CARDOIPULM book, Hilligas book here. And so let's go ahead and start with the reading.
Positioning for dyspnea relief. Dyspnea is defined as the sensation of difficult or labored breathing. 23. The patient may experience dyspnea at rest or after a period of activity. The therapist needs to be aware of other potential causes of dyspnea in addition to pulmonary dysfunction. These causes include myocardial ischemia, heart failure, and left ventricular hypertrophy. 23. The therapist should monitor for other signs and symptoms of intolerance to exercise with the occurrence of dyspnea. See box 17.4. When dyspnea is caused by pulmonary dysfunction, a patient may inherently find a position that allows for easier ventilation, with the arms supported. The accessory breathing muscles can act on the rib cage and the thorax, allowing more expansion for inspiration. The accessory muscles of the sternocleidomastoid, elevators, the scalenes, and the pectoralis major muscles. When the patient leans forward on supported hands, the intra-abdominal pressure rises and thus pushes the diaphragm up in a lengthened position. In view of the improved length-tension relationship, the diaphragm has an increased strength of contraction. Figure 17.7. The patient often experiences relief of the dyspnea in this position. Breathing exercises. A number of breathing strategies can be incorporated into treatment of a patient with cardiopulmonary impairments. Table 17.4. Traditionally, the following techniques have been described for use in rehabilitation and outpatient settings. However, they can be useful in the acute care setting as well. 1 of 24. Positioning for dyspnea. Pursed lip breathing. Pursed lip breathing is used to decrease a patient's symptoms of dyspnea. It has been shown to slow a patient's respiratory rate, decreasing the resistive pressure drop across the airways, thus decreasing airway collapse during expiration. 24. Airway collapse during exhalation presents in the advanced stages of chronic obstructive pulmonary disease, COPD. To employ pursed lip breathing, a patient is instructed to inhale through the nose for several seconds with the mouth closed and then exhale slowly over 4 to 6 seconds through lips held in a whistling or kissing position. This can be done with or without abdominal muscle contraction. 25. Paced breathing. Paced breathing is defined as volitional coordination of breathing during activity. During rhythmic activities, breathing can be coordinated with the rhythm of the activity. During non-rhythmic activities, the patient can be instructed to breathe in at the beginning of the activity and out during the activity. This can be combined with pursed lip breathing or diaphragmatic breathing. In the acute care setting, this technique can help the patient control his or her respiratory rate and associated feelings of dyspnea. 26. Inspiratory hold technique. An inspiratory hold technique involves prolonged holding of the breath at maximum inspiration. It can be used in conjunction with vibration techniques to aid in airway clearance. 27. It can also improve the flow of air into poorly ventilated regions of the lungs. 27. The patient is instructed to hold his or her breath without using a Valsalva maneuver at the heart of inspiration for 2 to 3 seconds. 28. Followed by a relaxed exhalation. Stack breathing. Stack breathing is a series of deep breaths that build on top of the previous breath without expiration until a maximal volume tolerated by the patient is reached. Each inspiration is accompanied by a brief inspiratory hold. 29. 2 of 24. Diaphragmatic controlled breathing. Diaphragmatic controlled breathing, with or without manual facilitation, can be used to manage a patient's dyspnea, reduce atelectasis, and increase oxygenation. This technique has been described as facilitating outward motion of the abdominal wall while reducing upper rib cage motion during inspiration. 18. The physical therapist can assess a patient's skill with this technique by observational, measuring abdominal excursion. Patients should be instructed in diaphragmatic breathing in all positions. As there is not necessarily carryover from one position to the next. 30. It is often easiest for patients to achieve a diaphragmatic breathing pattern while in the supine position. Once the patient has mastered the breathing pattern in the supine position, it can be attempted while sitting, then standing, then during activity. Diaphragmatic breathing can be achieved through a series of activities designed to decrease accessory muscle use and increase recruitment of the diaphragm. The first consideration is positioning. Positioning the patient with a posterior pelvic tilt can help facilitate use of the diaphragm. In the acute care setting, simply placing a towel roll under the patient's ischial tuberosities can help achieve this position. Next, it is important to help the patient relax the accessory muscles by verbal and tactile cueing. It may also be helpful to use the contract-relax technique. If the desired breathing pattern is not achieved using the previous techniques, sniffing can be added to help engage the diaphragm. The patient is positioned to eliminate gravity, either in the side-lying or semi-fowler position. The pelvis is positioned with a posterior tilt. The patient's hands are positioned on his or her abdomen for proprioceptive feedback, and the patient is asked to sniff 3 times and then exhale slowly. The therapist notes whether the patient is demonstrating an abdominal rise or rise in the area of the accessory muscles and gives this feedback to the patient. Next, ask the patient to sniff twice and then progress to 1 slow sniff. If this technique is successful, the therapist focuses on instructing the patient to perform sniffing more slowly and quietly until the patient is breathing in a relaxed manner. The patient is instructed to continue this technique independently. It may be useful as a relaxation technique or to control breathing during an activity such as ambulation. In the acute care setting, the presence of incisions, lines, and veins may prohibit the use of manual facilitation techniques. If this is the case, but 3 of 24. Techniques listed earlier can be used to help improve a patient's breathing pattern and manage symptoms. If the patient's medical management does not contraindicate the use of manual facilitation, techniques such as diaphragmatic scoop, lateral costal breathing, upper chest inhibiting technique, thoracic mobilization techniques, and chest wall stretches can be used. Another technique to help facilitate diaphragmatic breathing is the scoop technique. Again, the patient is positioned in either side lying on the semi-fowler position and with a posterior pelvic tilt. The therapist places a hand on the patient's abdomen and allows 2 to 3 breathing cycles to occur to become familiar with the patient's breathing pattern. After exhalation, the therapist scoops the hand up and under the anterior thorax, giving a slow stretch, and subsequently instructs the patient to breathe into my hand. The scoop stretch is repeated with each breath at the end of exhalation, and the patient is instructed to breathe into my hand during inhalation. As this improves the patient's use of the diaphragm, the therapist's hand can be removed. To progress the technique, it can be done in supine, then sitting, then standing positions, then with activity. The therapist can use the scoop technique at the beginning of each new position and then remove the hand as the patient becomes proficient in the breathing pattern in that position. Lateral costal breathing, unilateral costal expansion or bilateral costal exercises address one side or both sides, respectively, of the rib cage and corresponding intercostal muscles. Unilateral costal expansion exercises may be more useful in the treatment session with a patient who has a large incision from surgery on one side of the thorax. Splinting is a common reaction to incisional and post-operative pain. However, this may lead to decreased expansion on the respective side and prevent full alveolar ventilation. In addition, as incisions heal, they can bind to the underlying tissue and further limit chest wall expansion. Active range of motion, ERM, exercises mobilize the rib cage and when performed in conjunction with a variety of breathing techniques, help prevent scar immobility. This exercise is most efficiently performed in a side-lying position with the uninvolved side against the bed. The patient brings the arm on the involved side into an abductor position to the level of the head. The therapist gives a stretch before inspiration and continues giving resistance through the 4 of 24. Inspiratory phase, figure 17.8. Any contraindications to lying on a particular side need to be acknowledged before using unilateral costal expansion. For example, a patient who has undergone a left partial or whole lung removal may have precautions against lying on the left side. Unilateral costal expansion with resistance is also useful for the patients in the ARCU. These patients are often positioned inside lying for respiratory and integumentary considerations. Bilateral costal expansion is performed with the patient in a semi-reclined or sitting position. In this technique, the therapist places both hands on the lateral aspects of the rib cage and gently applies pressure against the ribs during inspiration. The patient can also be taught to perform this exercise independently. Upper chest inhibiting technique. Inhibiting the upper chest can help a patient recruit the diaphragm during inhalation. This technique should be used only after other techniques have been attempted. The patient is positioned inside lying, three-quarter supine or supine position. The diaphragm grip is used to facilitate the diaphragm while the therapist's other hand rests on the upper chest and moves with inhalation and exhalation. After assessing the patient's chest movement through a respiratory cycle, the therapist's arm follows the upper chest to the resting position on exhalation. When the patient inhales, the therapist's arm position does not move, thus applying pressure to the upper chest and resisting expansion. Add more pressure after each expiratory cycle until the patient increases lower chest breathing. When this occurs, encourage the patient to reproduce this breathing pattern and progressively release pressure on the upper chest with each breathing cycle while continuing to facilitate diaphragm movement with the other arm. 35 of 24. Thoracic mobilization techniques. If mobility of the thorax is restricted, it may be difficult for a patient to improve his or her breathing pattern through controlled breathing alone. It may be necessary to incorporate simple thoracic mobilization techniques to increase the ability of the thorax to expand during breathing. Simple positioning can be used to increase thoracic mobility. Placing a towel roll vertically down the thoracic spine while the patient is in a supine position can improve anterior chest wall mobility. Similarly, placing the patient inside lying over a towel roll can increase lateral chest wall mobility. Upper extremity movement can be paired with each position to increase mobility. The upper extremity is either actively or passively elevated to further stretch the affected areas. This technique can be progressed to sitting or standing positions. Counter-rotation technique can increase tidal volume and decrease respiratory rate by reducing neuromuscular tone and increasing thoracic mobility. It is effective for 1. Patients with impaired cognitive functioning after neurologic insult. 2. Young children who are unable to follow verbal cues. And 3. Patients with high neuromuscular tone. 30 briefly. This technique incorporates rotating the upper trunk to one side while the lower trunk is rotated in the opposite direction. 31. The patient is positioned inside lying with knees bent and arms resting in front. The patient should be in a comfortable position to facilitate relaxation. The therapist stands behind the patient, perpendicular to the patient's trunk. With one hand on the patient's shoulder and one hand on the patient's hip, the therapist assesses the patient's breathing cycle. Next, the patient is log rolled gently from the side lying position toward prone. At the same time, the therapist is audibly breathing with the patient. As the technique progresses, the therapist gradually slows audible cueing for a decreased respiratory rate. In phase 2, the therapist moves to stand behind the patient near his or her hips and faces the patient's head, and then the therapist changes hand position. If the patient is lying on the left side, the therapist slides the left hand to the patient's shoulder and the right hand to the patient's right gluteal fossa at the beginning of expiration. 6 of 24. Then, the therapist can facilitate more complete exhalation, compressing the rib cage manually at the end of exhalation by pulling the shoulder back and down and the hip up and forward. The opposite occurs during inhalation. The therapist slides the left hand to the patient's right scapula and the left hand to the patient's right iliac crest. During inhalation, the therapist stretches the chest by pulling the pelvis back and down and the scapula up and away from the spine. Initially, this is done along with the patient's breathing cycle and respiratory rate, but slows as the treatment progresses. Audible breathing cues slow along with the manual facilitation. The technique progresses by gradually decreasing manual input and then by eliminating verbal cues. 30. Butterfly. The butterfly technique is an upright version of the counter-rotation technique and can be used if the patient has good motor control. The patient sits unsupported, and the therapist stands either in front of or behind the patient. The therapist assists the patient with bringing his or her arms up into a butterfly position. The therapist breathes audibly with the patient. With inhalation, the therapist brings the patient's arms into increased shoulder flexion and lowers the arms during exhalation. The therapist then slows the audible breathing pattern and the facilitation of shoulder movement to encourage an increased tidal volume and decreased respiratory rate. The therapist can incorporate diagonal movement into the technique to facilitate increased intercostal and oblique abdominal muscle contractions. 30. Inspiratory muscle training. Inspiratory muscle training, IMT, is indicated for patients who exhibit signs and symptoms of decreased strength or endurance of the diaphragm and intercostal muscles. Signs and symptoms include, but are not limited to, decreased chest expansion, decreased breath sounds, shortness of breath, uncoordinated breathing patterns, bradypnea, and decreased tidal volumes. 32. 33. Patients with respiratory muscle weakness or fatigue may have such diagnoses as COPD, acute spinal cord injury, Guillain-Barré syndrome, amyotrophic lateral sclerosis, poliomyelitis, multiple sclerosis, muscular dystrophy, myasthenia gravis, or ankylosing spondylitis. 33. In addition, IMT may be indicated for patients on mechanical ventilation to improve weaning from ventilation. The goal of IMT is to increase the ventilatory capacity and decrease dyspnea. An IMT program has two parts, strengthening and endurance training. Each part will have increased 7 of 24. Decreased priority according to the needs and medical condition of the patient. Concepts of ventilatory muscle training are the same as those for other skeletal muscle training, incorporating the concepts of overload, specificity, and reversibility. 34. The overload principle applied to endurance muscle training requires low load imposed over longer periods. Specificity refers to training the muscle for the function they are to perform. For example, resistance applied to inspiratory versus expiratory muscles. Training effects may be lost over time if training is discontinued. The first step in any program is to teach a patient, if alert and oriented, the correct way to use the inspiratory muscles to ensure efficient inhalation. Including family members and support system members in the teaching can reinforce the program. Weakness of a muscle is the inability to generate force against resistance. The length of the muscle affects the force output, as demonstrated in the length tension curve, in the respiratory system. The strength of the diaphragm and other inspiratory muscles is measured as a function of standard pressure volume curves. 35. Weakness of the diaphragm will decrease the negative inspiratory pressure generated by the patient, and thereby decrease the volume of air inhaled. Patients with COPD have hyperinflated lungs and a flattening of the diaphragm, which alters the length-tension relationship of this muscle. Fatigue of the inspiratory muscles, particularly of the diaphragm, will result in failure to meet the demand for adequate alveolar ventilation. Hyperventilation will decrease the arterial partial pressure of oxygen, HAR2, and increase the arterial partial pressure of carbon dioxide, ACO2, and can lead to acute respiratory failure. The diaphragm is made up of all three types of muscle fibers, including slow-twitch oxidative, SO, fast-twitch oxidative glycolytic, FOG, and fast-twitch glycolytic, FG3638. The adult diaphragm is approximately 55% slow-twitch fibers, compared with about 10% in the infant. 39. Fatigue is related to the SO fibers, whereas weakness is attributed to the FG fibers. When initiating physical therapy treatment, the therapist should realize that all fibers need to be addressed in the cardiopulmonary treatment program. While mechanically supported on a ventilator, the diaphragm can lose 5% of its strength per day 40 when the patient begins the weaning process. The inspiratory muscles will gain endurance while performing inhalations without the assistance of the ventilator. Endurance training of the diaphragm will increase capillary density, myoglobin content, mitochondrial enzymes, and the concentration of glycogen. 8 of 24. Overall, it will increase the proportion of fatigue-resistant slow twitch fibers 41, 42. The recommendations include 2 to 3 daily sessions of 30 to 60 minutes of deep breathing, concentrating on using a diaphragmatic breathing pattern. 18. An early stage IMT technique is sniffing. Sniffing naturally enlists the diaphragm. With the patient in a comfortable position such as side-lying or reclined, the therapist may assist the patient in placing both hands on the abdominal area to provide proprioceptive feedback. Then, in a relaxed tone of voice, the therapist instructs the patient to sniff quickly through the nose 3 times with slow, relaxed exhalations. The therapist gives feedback throughout this technique on the quality of sniffing, assessing whether the patient is showing a diaphragmatic breathing pattern. If the patient is able to perform this effectively, the progression of this technique is to reduce the number of sniffs from 3 down to 1 at an increasingly slower pace. The goal of this technique is to increase the awareness of correct use of the diaphragm. The technique progression continues until the patient shows the diaphragmatic breathing pattern at a normal rate and depth for all levels of functioning. According to Massary and Fraunfelter, there is an 80% success rate with patients affected by primary pulmonary pathologies or neurologic impairments. 18. 43. Strength training can be performed in a number of different ways, depending on the initial strength of the diaphragm. One method that can be utilized easily for the patient achieving tidal volumes of 500 milliliters or better is resisted inhalation. This can be performed manually by the therapist. The therapist has the patient assume a comfortable position as described earlier to promote diaphragmatic excursion. The therapist gently places the hands just below the rib cage on both sides of the patient's thorax. Before the patient initiates an inspiration, the therapist gives a small amount of resistance to the diaphragm by pushing gently up and continues this pressure through the inspiratory phase. No resistance is given during exhalation. The therapist may also use weights for diaphragmatic strengthening. To evaluate if this is an appropriate method, the therapist first observes to determine where the normal diaphragmatic excursion occurs at rest and then with the addition of weights. The patient should be able to breathe comfortably and without accessory muscle for 15 minutes. If the amount of weight is excessive, the pattern of inspiration will become uncoordinated. 44. 9 of 24. Several authors suggest that strength training in this manner should include 2 or 3 sets of 10 repetitions once or twice a day. 9. However, with either the manual or the weights method, the quality of the contraction needs to be monitored. The patient should not be pushing with the abdominal muscles against the resistance, which enhances the exhalation phase of breathing rather than the muscles of inspiration. For a patient with fair or reduced diaphragmatic strength, tidal volume less than 500 ml, active breathing exercises are indicated without resistance. A patient with poor strength will find it difficult to exercise with the head of the bed elevated. A supine position will prevent the abdominal contents from pushing up on the diaphragm and limiting its excursion. Another form of resistive training utilizes specific handheld training devices, such as the P-Flex, DHT device, threshold, or the Peace pipe. The resistance is increased by decreasing the radius of the device's airway. The patient inhales through the device at a level that does not cause adverse effects, such as dyspnea or a drop in oxygen saturation. For a 15 to 30-minute session twice per day, 45 when this level is comfortable for the patient, then the resistance is gradually increased. Much controversy has surfaced regarding the efficacy of IMT since its introduction into clinical practice. Evidence has been presented both supporting and dismissing IMT as a reliable treatment method. A major discrepancy may exist in the diagnosis for which this treatment is prescribed. A patient with insult to the lung tissue itself, for example, COPD or ARDS, may not tolerate IMT. Inspiratory muscle training, which is a strengthening exercise, would increase the demand for oxygen delivery in the diseased lungs. However, a patient with a neuromuscular disease and intact lungs may be more likely to tolerate the increased oxygen demand and derive a benefit, as would the patient on mechanical ventilation who is trying to be weaned from the ventilator. Deep breathing exercises are indicated for the patient with atelectasis, which is caused by hyperventilation and the collapse of alveoli in the lungs. 18. The use of an incentive spirometer is an effective way to practice diaphragmatic breathing. Prevent or reverse atelectasis and stimulate a cough. Figure 17.9. Often, it is given to the patient preoperatively so he or she can practice deep breathing. Then, after surgery, the patient may be able to perform this technique from memory as the effects of anesthesia start to diminish. 10 of 24. The patient is instructed to perform deep breathing exercises with the incentive spirometer 10 times every hour to replenish surfactant, which is lost in the presence of atelectasis. 32. The patient needs to be instructed to perform a slow, relaxed breath through the mouthpiece. It is often helpful to have the patient place a hand on the abdominal area to feel the diaphragm working in the correct way. If the patient is having a difficult time performing this technique, the therapist may place a hand over the patient's hand to facilitate the proper technique. Then the therapist should instruct the patient to perform the breathing slowly, with the abdomen rising up during inspiration. The goal is for the patient to be able to use the incentive spirometer independently without proprioceptive or verbal feedback. Alternatively, early mobilization has been shown to be as effective as deep breathing exercises after gallbladder and cardiac bypass surgery. 46-48. Clinical tips: surfactant production is reduced post-operatively, making patients at risk for serious pulmonary complications such as pneumonia and respiratory failure. Surfactant's role is to reduce surface tension and prevent alveolar collapse. Atelectasis. Surfactant is produced by the type 2 pneumocytes in the alveoli of the lungs. By expanding the alveoli and stretching the type 2 pneumocytes with deep breaths, surfactant production is stimulated. Deep breathing is the most effective way to prevent alveolar collapse that, without intervention, can lead to more serious post-operative pulmonary complications. 11 of 24. Examination of the patient with heart disease. Owing to the increasing incidence and prevalence of heart disease on our society, many patients referred to physical therapy will have cardiovascular dysfunction or may be at risk for developing CVD. The history taking, review of systems, and data from specific tests and measures will guide and inform development of the physical therapy diagnosis, goals and outcomes, prognosis, and POC. This section addresses elements of the examination and tests and measures specific to the cardiovascular system. Medical record review. The medical record of a patient with a history of cardiovascular impairments may at times be overwhelming. The patient interview is typically helpful if clarification of the medical record is needed, depending on the type of setting: inpatient, outpatient, acute rehabilitation, home care. Specific contents of the medical record may vary. Important items to note within the medical record include the following. 1. Medical problems, past medical history, physician's examination. 2. Medications, including type, dosage, and schedule. 3. Laboratory tests, blood tests for specific cardiac enzymes that may indicate an MI has occurred, such as a positive CKMB or troponin level. Electrolytes, including potassium, and magnesium and calcium if ventricular arrhythmias are present. Complete blood count, CBC, which may indicate the presence of anemia via the hemoglobin and hematocrit values. Status of the kidney, bone and creatinine, and liver function. Liver function tests, presence of CAD risk factors, such as elevated lipid values, for example, total cholesterol, low-density lipoproteins, LDLs, triglyceride, and elevated blood sugars, glucose, arterial blood gases, ABGs. 4. Results of any diagnostic studies or interventions, chest X-ray, ECGs, ET, cardiac catheterization, surgical reports, hemodynamic monitors, for example, pressure readings from central line and arterial line. 5. Nursing and other healthcare provider notes. The medical record contains information regarding what has happened to the patient, as well as the status of the patient within the last 24 hours or since the last healthcare provider intervention. Flow charts, which record vital signs, temperature, oxygenation requirements, and volume status over time, provide up-to-date patient data, especially when working with a more medically challenged patient. Patient interview. The formal patient interview should follow the medical record review. A determination of overall cognition, for example, orientation, memory, learning needs, comprehension, should be made. Information regarding the patient's lifestyle, previous level of 12 of 24. Functioning, recreational interests, work requirements, and goals is important in establishing the intervention. The International Classification of Functioning Health and Disability recommends the clinician evaluate environmental and personal factors that affect a patient's overall ability for activity and participation. 70 Based on this model, it is important for therapists to assess the patient's prior level of participation in addition to the prior level of activity. An assessment of both baseline activity and participation is useful in generating goals and the appropriate functional prognosis of the patient. Further, an assessment of an individual's prior level of function should not only be limited to the level of function before the most recent hospital admission. Oftentimes, when a patient is asked their level of function before the most recent hospital admission, the therapist assumes that this level of function before the most recent admission is the patient's optimal level of function. This may not be true for a patient who had a higher level of function a few months earlier who now presents with a relatively lower level of function at this admission due to multiple recent readmissions. Clinically, it is useful to interview patients on their level of function over a prolonged length of time prior to their current state. Data should also be obtained about the patient's response to health and illness, coping status, support systems, and knowledge of heart disease. It is important to note that not all the information from the interview needs to be obtained on the first session. During subsequent sessions, the patient may begin to feel better and less anxious and may therefore be able to communicate more easily. Patient education can often be woven into the interview process, either subtly or overtly. The patient should describe, in his or her own words, the quality and location of the symptom for which medical attention is being sought. It is common for physical therapists to ask a patient about pain. For patients with cardiac disease, one should be cautious about assuming that the patient's symptom is pain. Many patients will not use pain as their qualifier, but instead describe their symptoms as pressure, heaviness, sob, dyspnea, aching, heartburn, or cerebral malaise, to identify a few. Knowing the symptom presentation for each individual will make patient education and activity progression easier. It is also important to identify any consistent precipitating factors and alleviators, as well as duration and frequency of symptoms. The interview also helps to establish rapport and trust between therapist and patient, creating an environment for mutual goal setting. This in turn facilitates 13 of 24. Patient adherence to the rehabilitation program. Patients who are recovering from an MI or from surgery need to understand the time frames for healing and convalescence. Education for family members and significant others is also crucial for patient adherence and understanding. 14 of 24. Tests and measures following the International Classification of Functioning Health and Disability. Specific examination tests and measures are presented to identify impairments in body structure and function. Table 13.9. And in functional activity limitations and participation restrictions. Table 13.10. Table 13.9 Outcome measures. Patients with cardiovascular disease, body structure and function impairment. Key test measure baseline hemodynamic stability, resting heart rate and rhythm. These must be assessed at rest and with activity. Normal resting heart rate is 60-100 beats per minute. Alterations in heart rate values from this range at rest must be evaluated to determine the stability of the patient at rest. Beyond an assessment of the absolute heart rate value at rest, it is also important to consider relative changes in resting heart rate values on a day-to-day basis to determine the relative stability of the patient. In other words, a patient with a routine resting heart rate of 60 beats per minute who presents on any given day with a heart rate of 80 beats per minute may be demonstrating relative instability due to an exacerbation of their pathology. Finally, if peripheral pulse is difficult to obtain, an apical pulse may be obtained by auscultating the heart at the fifth intercostal space, mid-clavicular line. Baseline hemodynamic stability, heart rhythm. The regularity of the pulse is important to assess to determine the presence of an arrhythmia. Pulses may be felt as regular, irregular, regularly irregular, or irregularly irregular. A patient who presents with any form of irregularity in their pulses will need a follow-up EKG to confirm the dysrhythmia. Hemodynamic stability with exercise. 15 of 24. Exercise heart rate and rhythm. An assessment of heart rate and rhythm during exercise is important to help determine the appropriateness of the cardiovascular system in meeting the metabolic needs of the body during exercise. Heart rate traditionally increases 10 beats per minute, the metabolic equivalent, MET, level increase in activity. The inability to increase heart rate sufficiently or a profound increase in heart rate with activity needs further evaluation. Further, it is important to evaluate heart rate responses with activity each day to determine the relative stability of the patient on a day-to-day basis. In other words, an assessment of the patient's relative changes in heart rate to the same absolute work is useful in identifying stability on a day-to-day basis. Hemodynamic stability with exercise. Respiratory rate. Normal respiratory rate at rest in an adult is 12-20 breaths minute. Respiratory rates greater than 30 breaths minute at rest signifying stability and will need further assessment. Further, it is important for the clinician to assess respiratory rate changes during activity at each visit to assess relative changes in stability on a day-to-day basis. Hemodynamic stability with exercise. Blood pressure with activity. Arterial BP is a product of CO and total peripheral resistance, TPR. With BP equals CO TPR, an increase in either of these factors will increase BP, and a decrease in either may decrease BP. The primary factor that changes during activity is the CO and not the TPR. Therefore, clinically, the change in blood pressure during activity is primarily due to a change in pump and aerobic exercise of increasing intensity increases CO and concomitantly increases BP. Conversely, a drop in BP during aerobic exercise indicates a drop in CO or signifies the inability of the heart to meet the metabolic needs of the peripheral tissue. Signs of compromised CO, including fatigue, weakness, tiredness, dizziness, usually accompany this drop in BP. Therefore, BP is essential to assess in a patient who demonstrates signs of compromised CO during activity to determine where the CO is being maintained. 16 of 24. Hypoxemia pulse oximetry. Pulse oximetry is used to assess pulmonary respiration or gas exchange at the level of the alveolar capillary interface. Pulse oximetry readings less than 90% indicate hypoxemia and warrant further evaluation. Dyspnea. Dyspnea may be assessed by asking patients their perceived level of dyspnea on a scale of 1-10. 0 equals nothing at all. 10 equals maximal. High reliability and validity have been reported. 71 further. A minimal clinical important difference has not been established in heart disease but has been established as 1 point in patients with chronic lung disease. 72 an alternate method for measurement is the dyspnea scale, a 5-point ordinal scale. 0 equals no dyspnea. 4 equals severe difficulty. Cannot continue. Box 13.3. Altered breathing patterns. Paroxysmal nocturnal dyspnea. An assessment of a patient's report of experiencing a sudden episode of shortness of breath at night is an important sign of an exacerbation of heart failure. It has a sensitivity and specificity of 39% to 41% and from 80% to 84%, respectively. 73 altered breathing patterns. Orthony. Orthony is shortness of breath that increases in the recumbent position. This sign has a reported sensitivity of 22% to 50% and a specificity of 74% to 77% for heart failure exacerbation. 73 patients with heart failure require increased numbers of pillows to sleep at night to avoid symptoms of orthony. Therefore, clinically the number of pillows required can be used to gauge the severity of heart failure. Dyspnea on exertion. Dyspnea on exertion. Dyspnea, especially with exertion, is one of the most common symptoms of heart failure, and it frequently appears early in the 17 of 24. Disease. Dyspnea on exertion has a sensitivity of 84% to 100% in the diagnosis of heart failure, but the specificity is much lower, ranging from 17% to 34%. 73 baseline instability and heart failure displacement of the point of maximum impulse. EMI. The apical impulse is traditionally auscultated at the midclavicular line. An apical impulse recorded greater than 3 centimeters from the midclavicular line may be an accurate indicator of left ventricular enlargement with a sensitivity of 92% and a specificity of 91.74. Angina. The classical presentation of angina is substernal chest pressure accompanied by the Levine sign. The patient clenching his or her fist over the sternum. The Levine sign has a high diagnostic accuracy for ischemia, 75 for some patients. Angina does not present in the classic way but rather may present as a pain or heaviness in the shoulder, jaw, arm, elbow, or upper back between scapulae. Angina may radiate from the chest to the arm or up to the throat, or it may present as indigestion or even sob. The patient is often asked to rank his or her discomfort on the angina scale. Box 13.4. Abnormal heart sounds. Heart auscultation. Normal heart sounds are identified as S1, lub, which occurs at the time of the closure of the mitral and tricuspid valve and marks the beginning of systole, and S2, dub, which occurs at the time of aortic and pulmonic valve closure and marks the end of systole. Figure 13.17 depicts locations on the chest for appropriate auscultation of each valve. The aortic valve is best auscultated at the second intercostal space, right sternal border. The pulmonic valve is heard at the second intercostal space, left sternal border. The tricuspid valve is auscultated at the fourth intercostal space, left sternal border, and the mitral valve is best heard at the fifth intercostal space, along the midclavicular line. Murmurs are abnormal heart sounds, commonly the result of valvular disorders due to the changes in blood flow around and through the altered valve. A systolic murmur will present as audible turbulence between S1 and S2, and a diastolic murmur is turbulence between S2 and S1. Other abnormal sounds include a S3 and S4. S3, also known as a ventricular gallop, occurs after S2 and is clinically associated with acute heart failure. 18 of 24. Decompensation with a specificity of 99.73 S4, also known as an atrial gallop, occurs before S1 and is clinically associated with an MI or chronic HTN. Finally, pericardial friction rub in acute pericarditis has 100% specificity and 9% sensitivity. For abnormal lung sounds, lung auscultation, normal lung tissue produces vesicular, soft, low-pitched sounds in the peripheral aspect of the lungs and bronchial breath, loud, high-pitched sounds centrally along the manubrium of the sternum. Patients with 55 inches failure often have the adventitious sounds of crackles. The auscultated crackles are coarse and best appreciated over the lung bases. The crackles typically occur late in inspiration. 76 Figure 13.18 demonstrates appropriate sites for the auscultation of lung fields. Baseline instability due to increased cardiac filling pressures, jugular venous distension. Patients with heart failure presenting with backup of fluid into the venous vasculature should be examined for the presence of jugular venous distension. To examine for this sign, the patient is placed at a 45-degree semi-recumbent position. 77 The patient's head is turned away from the side to be evaluated, and the clinician observes for a distension or pulsations of the jugular vein 3 to 5 centimeters above the sternum. The highest point of visible pulsation is determined when the vertical distance between this level and the level of the sternal angle of Louis is recorded. Figure 13.19. Jugular venous distension has 94% specificity and 39% sensitivity in determining increased cardiac filling pressures. 77 Peripheral edema, pitting edema, and weight gain. In patients with congestive heart failure, low SV causes a reduced blood volume perfused to the periphery. This stimulates the presoreceptors as they sense a decrease in volume. These presoreceptors subsequently relay a message to the kidney to retain fluid. This retention of fluid increases the hydrostatic pressure within the peripheral vasculature, thereby pushing fluid into the interstitial space, resulting in peripheral edema and weight gain. Edema can be assessed through both measurements or by using the palpation pitting scale. Chapter 14. The severity of peripheral edema. 19 of 24. is categorized into 4 stages based on the time taken for the skin to rebound to its original contour after lifting. It is also important to note that edema can accumulate in the abdominal area, ascites, or sacral areas of the body. Peripheral muscle weakness, muscle strength. Standard manual muscle testing of major muscle groups in the upper and lower extremities is effective if weakness is suspected below functional limits. If strength of peripheral muscles is above functional limits, assessment of functional strength can be performed with a standardized sit-to stand test called the 5 times sit-to-stand test, or a timed chair rise test called the 30-second chair rise test. Inspiratory muscle weakness, maximal inspiratory pressure. Strength of the inspiratory muscles is important in patients with heart failure. Empirical evidence suggests that patients with chronic heart failure have weak inspiratory muscles. 78 and inspiratory muscle strength of less than 60 centimeters H2O traditionally depicts the presence of weak inspiratory muscles. 20 of 24. Table 13.10 Outcome measures, activity limitations, and participation restrictions in patients with cardiovascular disease. Activity and participation and limitation. Key test measure activity. Cardiovascular conditioning walk tests. A variety of walk tests are used to assess endurance in the patients with cardiopulmonary compromise. 2 such tests include the 6-minute walk test, 6MWT, and the 2-minute walk test, 2MWT, where a participant is asked to ambulate back and forth continuously on a promedian walkway for 6 minutes or 2 minutes, respectively. 6MWT. The American Thoracic Society, ATS, has published guidelines for administering the 6MWT. 79 Shoemaker and colleagues report a minimal clinically important difference, MCID, for the 6MWT in patient with heart failure to be 45 meters AT. The researchers found that this change of 40 meters to 45 meters is a change that is greater than the measurement error and correlated with improvements in aerobic capacity and heat-related quality of life. 80 Further, in a large study, Comuri and colleagues found 6 megawatts distances of less than 400 meters on the day of hospital discharge revealed significantly greater 30-day readmission rates compared with patients with HF and higher 6MWD scores. 81 patients requiring readmission within 30 days had a median 6 megawatts distance of 30 meters, whereas patients not requiring readmission at 30 days walked significantly more with median score of 338 meters. 81 2MWT. In this test, the subject was asked to walk for 2 minutes. The total distance covered in 2 minutes is measured. The subject was allowed to use assistive devices when performing the test. Subject is asked to walk at a safe and comfortable pace. No verbal cues are provided during the test. Activity cardiovascular deconditioning 2-minute step test. The 2MST was initially developed by Rickley and Jones when space limitation or weather prohibited the subject from performing a 6MWT or 2MWT. 82 subjects are asked to attain a standing position near a wall, doorway, next to a high back chair or countertop. Because this is not a test of balance, the subject is allowed to hold on to the high countertop or chair for support. In this test, the subject is asked to step in place for 2 minutes. Stepping involved. 21 of 24. Flexing the hip and the knee to a height that is midway between the iliac crest and the knee on the opposite side. Stepping on both sides, right and left, counts as a single step. The score recorded is the total number of correct height steps taken by the one of legs within 2 minutes. If the knee height can no longer be maintained, the participant is asked to stop or to stop and rest until proper form can be regained. During rest intervals, the clock continues to run. Activity cardiovascular conditioning exercise tolerance tests, ET, to examine the ability of the cardiovascular system to accommodate to increasing metabolic demand. An ET, stress test, or graded exercise test is performed. The patient exercises through stages of increasing workloads, expressed in units of oxygen. Oxygen cost may be expressed in L-min, mLO2 per kilogram min, PAL, or metabolic equivalents, METs. The MET represents a factor of the basic systemic oxygen requirement at rest, roughly 3.5 milliliters O2 per kilogram min. The most common modalities used in exercise testing of patients with cardiac impairments are the treadmill, bicycle, and ergometer. Figure 13.20. The best indicator of an individual's aerobic capacity is through examination of the peak oxygen uptake or VO2 max, an anaerobic threshold measured through use of a metabolic cart. When expensive equipment like a metabolic cart is not available, field tests such as the step test, bicycle tests and walk tests can be useful in predicting the maximal oxygen consumption from the submaximal steady-state heart rate. A multitude of tests are available to quantify exercise capacity. An excellent resource for these tests is the American College of Sports Medicine's Guidelines for Exercise Testing and Prescription. Activity, decreased balance tests of balance and full risk, a variety of functional tests including the timed up and go test, verb balance test, and 10-meter walk test measuring gait speed 85 can be utilized in assessing a patient's balance and full risk. Activity, decrease mobility, 22 of 24. No speakable content could be found. Activity measured for post-acute care. AMPAC. The AMPAC is an outcome measure that assesses function in three major domains: basic mobility, daily activities, and applied cognitive. 86. 87. The primary goal for the development of this measure was to create a single measure to effectively measure function across all care settings within the continuum of care following an acute care stay. The AMPAC is a patient-reported outcome measure and therefore captures the patient's perspective. The measure is available in two basic formats: a computer-based version and a short-form version. Activity, decrease mobility. Mobility measures in post-acute care. Depending on the care setting, a variety of measures exists to document a patient's activity and functional status, including the Functional Independence Measure, FIM, commonly used in inpatient rehabilitation facilities, the Minimum Data Set, MDS, used in skilled nursing facilities, and the Outcome and Assessment Information Set, OASIS, that is primarily used in home care. See Chapter 7. Participation Quality of Life Minnesota Living with Heart Failure Questionnaire, MLHFQ. The MLHFQ is a patient self-assessment of how heart failure affects a patient's daily life. It was developed by Thomas Rector in 1992 and since then has been used in multiple research investigations as a measure of quality of life in patients with heart failure. The approximate time to complete the questionnaire is 5 to 10 minutes. The content reflects most frequent and important ways heart failure affects patients' lives. All items are assessed on a 1-5 Likert scale. Sum of item responses allows for total and individual dimension scores. The test. Retest reproducibility assessed by Rector and colleagues is a Pearson correlation of 0.8788. Internal consistency measured by Cronbach's alpha for all items is 0.9288. The minimally important difference is 5 points on the total score, 89 in addition. The estimated standard error of the measure is 6-7 points, 89. 23 of 24. Participation Quality of Life Seattle Angina Questionnaire, SAC. The SAC is an outcome measure that is utilized to assess the impact of angina in a patient's quality of life within the previous 4 weeks of the assessment date. The survey uses 19 items to assess the severity of limitations in everyday life. There are two distinct sections of the survey: the impact of angina on the patient's ability for completing ADLs, and the second section involving several questions that assess the patient's health conditions. The measure has been a validated disease-specific health status instrument for coronary artery disease, CAD, with high test-retest reliability, predictive power, and responsiveness. Its use in routine clinical practice, 91. However, its use has been limited by its length, 19 items. Therefore, in 2014 a short version, 7 items, was developed, tested, and validated to increase the feasibility of measuring patient-reported outcomes in patients with 91 Canadian dollars. 24 of 24.
Okay, so that is the end of the reading. And since it's almost an hour, I'm going to stop and make this a part 1 and a part 2. So look for part 2.